Welcome to this episode. Today, we're diving into two of the most critical postpartum complications, postpartum hemorrhage and venous thromboembolism. Both remain leading causes of maternal mortality worldwide, and understanding their nuances is essential for clinicians managing postpartum care.
Absolutely. What's striking is how postpartum hemorrhage, or PPH, can happen so suddenly and often be underestimated, while venous thromboembolism, or VTE, carries a significantly elevated risk during pregnancy and postpartum. Early recognition and multidisciplinary management are key to improving outcomes.
Right. So let's start with PPH. Traditionally, it's defined as blood loss of 500 milliliters or more after vaginal birth, and 1,000 milliliters or more after a cesarean. But these thresholds are somewhat arbitrary, aren't they?
They are. Some patients tolerate those volumes without any hemodynamic instability. More clinically relevant is a 10% drop in hemoglobin, or the need for transfusion. Plus, visual estimation of blood loss is notoriously inaccurate, often underestimating by a third to over half, which can delay critical intervention.
Yeah, that's a huge challenge. So the practical approach is to treat any blood loss that causes or could cause hemodynamic instability as PPH. And that threshold varies depending on the patient's baseline condition.
Exactly. And PPH is classified as primary or secondary. Primary occurs within 24 hours of birth, while secondary happens between 24 hours and up to 12 weeks postpartum, often due to retained placental tissue or infection.
That classification helps guide clinical reasoning. Now, the 4 teraseconds framework is a really useful mental model for PPH etiology: tone, tissue, trauma, and thrombin.
Yes, starting with tone. Uterine atony is the leading cause of early PPH. It's essentially marked relaxation or hypotonia of the uterine smooth muscle. Normally, uterine contraction compresses the maternal blood vessels at the placental site, preventing hemorrhage.
So if the uterus is flaccid after delivery, bleeding continues unchecked. Risk factors for uterine atony include overdistension from a large fetus, multiple gestations or polyhydramnios, high parity, prolonged or oxytocin-induced labor, magnesium sulfate administration, chorioamnionitis, previous uterine atony, and fibroids.
The analogy I like is thinking of the uterus as a basket weave of interlacing smooth muscle bundles. When it contracts, it tightens around the blood vessels like a clamp. If it's relaxed, the vessels remain open and bleeding continues.
That's a great way to visualize it. Moving on to tissue causes. Retained placental fragments or abnormal placentation can cause PPH. Retained placenta is defined as failure to deliver the placenta within 30 to 60 minutes after birth, despite gentle traction and uterine massage.
Causes include partial placental separation, presence of succenturiate lobes, entrapment by uterine constriction rings, or abnormal adherence. And then there's the placenta accreta spectrum: placenta accreta, increta, and percreta, where the placenta invades the myometrium to varying depths.
The incidence of placenta accreta spectrum is rising, largely due to increased cesarean rates. Prenatal diagnosis with ultrasound and MRI is critical to plan delivery and avoid catastrophic hemorrhage.
Right. Attempting manual removal of an adherent placenta can cause severe bleeding and uterine damage. In some cases, hysterectomy is necessary if bleeding is uncontrollable.
Trauma is the third T. This includes lacerations of the birth canal, extensions or lacerations during cesarean, uterine rupture, and uterine inversion.
Lacerations are classified by degree, from first to fourth, with episiotomies sometimes extending to third or fourth degree. Persistent bleeding despite a firm uterus should raise suspicion for trauma.
Hematomas, vulvar, vaginal, or retroperitoneal can cause concealed bleeding. Retroperitoneal hematomas are rare but potentially fatal, often associated with rupture of a cesarean scar.
Uterine inversion is a rare but life-threatening complication where the uterus turns inside out, sometimes protruding through the vagina. It can be incomplete, complete, or prolapsed.
Contributing factors include a short umbilical cord, fundal placenta, excessive cord traction, uterine atony, and inappropriate fundal pressure. It presents suddenly with hemorrhage, shock, and pain, and the uterus is not palpable abdominally.
Emergency management involves fluid resuscitation, repositioning the uterus, using tocolytics to relax the uterus before replacement, then uterotonics after repositioning. Prevention is key. Never pull the cord before placental separation.
The last T is thrombin, coagulopathies that cause continuous bleeding without an obvious source. Rapid assessment of coagulation status is essential.
Causes include pre-existing disorders like von Willebrand disease and immune thrombocytopenic purpura, pregnancy-related thrombocytopenia with pre-eclampsia, and disseminated intravascular coagulation, or DIC.
Von Willebrand disease is the most common hereditary bleeding disorder in childbearing women. It involves deficiency or defect in von Willebrand factor, which is crucial for platelet adhesion and stabilizing factor VIII.
Symptoms include mucosal bleeding, easy bruising, and heavy menstrual bleeding. Interestingly, factor VIII rises during pregnancy, but VWF decreases postpartum, increasing bleeding risk.
Treatment involves desmopressin to release VWF and factor VIII, and plasma transfusions if needed.
Immune thrombocytopenic purpura is an autoimmune destruction of platelets, which can cause severe postpartum bleeding. Management includes corticosteroids, IVIG, platelet transfusions, or splenectomy if refractory.
DIC is a pathological widespread clotting that consumes clotting factors, leading to bleeding. It can be triggered by massive hemorrhage, sepsis, HELLP syndrome, amniotic fluid embolism, or fetal demise.
Clinically, you see spontaneous bleeding, petechiae, and hypotension disproportionate to blood loss. Labs show low platelets, fibrinogen, prolonged PT and PTT, and elevated fibrin split products.
Management focuses on treating the underlying cause, volume replacement, blood components, and critical care support.
Now, hemorrhagic shock is a critical consequence of PPH. It results from inadequate tissue perfusion due to blood loss.
Early signs include tachycardia, tachypnea, anxiety, and cool, pale skin. Late signs are hypotension, lethargy, and decreased urine output below 30 milliliters per hour.
The body's compensatory mechanisms divert blood flow to the brain and heart, constricting vessels in the skin and kidneys. But prolonged shock leads to lactic acidosis, vasodilation, and multi-organ failure.
Treatment requires rapid IV fluid resuscitation, about 3 milliliters of crystalloid for every milliliter of blood lost. Blood transfusion if bleeding continues, establishing 2 large-bore IV lines, oxygen administration, and correcting the bleeding source.
Invasive hemodynamic monitoring, like arterial lines or central venous pressure monitoring, and continuous ECG may be necessary. Nurses play a critical role in frequent assessment, monitoring urine output, vital signs, and early recognition of deterioration.
Speaking of nursing, active management of the 3rd stage of labor is recommended to prevent PPH. This includes oxytocin administration immediately after delivery of the anterior shoulder, delayed cord clamping, gentle cord traction, and fundal massage with IV oxytocin after placenta delivery.
If placenta delivery takes longer than 30 minutes, the risk of PPH increases significantly.
Uterotonic medications are central to management. Oxytocin is first line, promoting uterine contraction, though water intoxication is a rare side effect.
Misoprostol, a prostaglandin E1 analog, can be given rectally, sublingually, or orally, with side effects like fever and diarrhea. Methylergonavine produces sustained contractions, but is contraindicated in hypertension or cardiac disease.
Carbaprostromethamine, a prostaglandin F2 alpha analog, should be avoided in asthma or hypertension. Tranexamic acid, an antifibrinolytic, is used off-label to reduce bleeding, but contraindicated in patients with a history of thrombosis or on anticoagulants.
Nursing interventions include firm uterine massage, expression of clots, emptying the bladder to avoid uterine displacement, continuous IV oxytocin infusion, and quantitative monitoring of bleeding by weighing pads rather than visual estimation.
If bleeding persists, escalation includes bimanual compression, manual exploration for retained tissue, and surgical options like uterine tamponade, arterial ligation, compression sutures, or hysterectomy.
Now shifting gears to venous thromboembolism. Pregnancy increases VTE risk about 15-fold compared to non-pregnant women, with an incidence of roughly 1 in 1,500 pregnancies.
Deep vein thrombosis is more common during pregnancy, while pulmonary embolism is more common postpartum. Despite preventative measures, PE remains a leading cause of maternal death.
The pathophysiology aligns with Virchow's triad: venous stasis, hypercoagulability, and endothelial injury. Pregnancy and postpartum promote stasis and hypercoagulability.
Additional risk factors include cesarean birth, which doubles the risk, operative vaginal delivery, history of thrombosis or varicosities, BMI over 30, prolonged immobility, smoking, and complications like preeclampsia, hemorrhage, or infection.
Clinically, superficial venous thrombosis presents with pain, tenderness, warmth, and redness over the saphenous vein. DVT shows unilateral leg pain, calf tenderness, and swelling, though it can be asymptomatic.
Pulmonary embolism presents emergently with dyspnea, tachypnea, tachycardia, cough, hemoptysis, and sometimes syncope.
Diagnosis involves D-dimer assays and imaging, ultrasound for DVT, ventilation perfusion scanning, or CT pulmonary angiography for PE.
Treatment for superficial thrombosis includes NSAIDs, rest, leg elevation, compression stockings, and heat. DVT requires initial IV heparin, bed rest with leg elevation, analgesia, then transition to oral warfarin for about 3 months.
For PE, emergent IV heparin is started, followed by subcutaneous or oral anticoagulants for up to 6 months. Breastfeeding mothers can safely use heparin and warfarin, but infant prothrombin time should be monitored if the mother is on warfarin.
Nursing care involves frequent assessment of the affected limb, inspection, palpation, circumference measurement, and monitoring for signs of PE like respiratory distress.
Monitoring labs for coagulation profiles and assessing for unusual bleeding is critical. Nurses also educate patients and families on medication administration, side effects, and bleeding precautions.
Patients on bed rest need assistance with personal care and should be encouraged to change positions frequently, avoiding sharp knee flexion to prevent venous pooling.
They should be cautioned not to rub affected areas to avoid dislodging clots.
Discharge instructions include pain management with position changes, leg elevation, moist heat, and analgesics. Patients need guidance on medication adherence, dietary restrictions, especially limiting vitamin K-rich foods with warfarin, and safe care practices to minimize bleeding risk.
Follow-up for clotting times is essential, and patients should use reliable contraception since warfarin is teratogenic. Oral contraceptives are contraindicated due to increased thrombosis risk.
To wrap up, PPH remains a leading cause of maternal mortality, and early recognition with the 4 teraseconds framework is vital. Uterine atony is the most common cause, but trauma, tissue issues, and coagulopathies must be considered.
Hemorrhagic shock demands aggressive fluid resuscitation, blood transfusion, and close monitoring. VTE risk is markedly increased in pregnancy and postpartum, requiring prevention, early diagnosis, and anticoagulation.
Nursing care is pivotal throughout: monitoring, intervention, patient education, and emotional support. Multidisciplinary collaboration and adherence to protocols improve outcomes significantly.
Thanks for joining us in this deep dive. We hope this discussion enhances your clinical approach to these complex postpartum complications.
Take care.